So, buddy, the next video, no, this another small video is on carcinoma of prostate. This is important cancer because this is the most common malignant cancer if the male is more than 65 years of age, right? Most common genetic mutation is GSTP1, right? Glutathione S transferase pi, found on chromosome number 11. Another risk factor, BRCA1 and 2. Remember, BRCA1 and 2 both are commonly, associated with increased ovary, colon, and prostate cancer. Now, what is the important risk factor? Age, height, testosterone levels, alcohol, smoking. Now, I told you it's commonly seen in the posterior lobe peripheral zone. Posterior lobe peripheral zone. It's an adenocarcinoma because it is arising from the glands. Now, since the cancer is arising very far away from the urethra, there will be no urethral symptoms which are seen due to adenocarcinoma, right? Your patient can have urethral symptom because of coexisting BHP, benign hyperplasia of prostate, but adenocarcinoma itself will not cause any special urethral symptoms. Now, it may go to the spinal cord, the vertebrae, then it may cause low back ache. If you do the digital rectal examination, you will notice that there is a hard nodule and you'll not be able to feel the median raphe, right? Now, investigation of choice to make the diagnosis is TRUS guided biopsy, transrectal ultrasound guided biopsy. Cancer can be very small in focus, so you need to take minimum 12 biopsies. What is the investigation of choice to see the associated lymph nodes? MRI. What is the investigation of choice for overall staging? PET-CT. Now, PSA levels will be high. If the PSA levels are more than 10 nanogram, they are suggestive of cancer. If the PSA levels are more than 35 nanogram, they're suggestive of metastatic cancer. How to see that the cancer has gone to the bones? We use technetium scan, right? Carcinoma prostate staging, I'm afraid this is important. When I say that breast cancer staging is the only staging which is important, yes, that's partially true. Carcinoma prostate staging is equally important, right? Now, what is the investigation of choice? Multiparametric MRI. That's the best investigation for local staging, T staging, what we call it. Now, T1 is a cancer which is incidentally discovered. You did the surgery on prostate, and while you sent the tissue for biopsy, you notice that the tissue has got cancer. Now, the substages. T1A, cancer is found in less than 5% of the tissue. T1B, cancer is found in more than 5% of the tissue. T1C, cancer was not clinically palpable, but you did the biopsy. Why you did the biopsy? Because the PSA levels were high and you found the tumor. T2, tumor is now clinically apparent as a hard nodule. Now the substages, there is a single nodule in one lobe. Then T2B, the, the nodule is affecting more than half of the lobe. T2C, the nodule is present in both the lobes. Now you see, till now the cancer is still inside the prostate. T3, cancer will breach the prostate capsule, it will come out. T3A just comes out, microscopic focus is there. T3B, the cancer reaches seminal vesicles. T4, the cancer is fixed to adjacent structure like sphincter, levator muscles, and bladder neck. About the N staging, naturally N0, no lymph nodes, N1, the regional lymph nodes. The first lymph nodes to be affected would be obturator lymph nodes. That's the only thing which is important here. M0, no metastasis. M1A, non-regional lymph nodes, which are not directly close to the prostate. For example, external iliac and supraclavicular lymph nodes. M1B, B stands for bones. So, if the tumor goes to the bones, and most commonly it will go to lumbar vertebrae. M1C, if the cancer goes to other sites, right? It can go anywhere through the blood. Now, secondaries in the bone, they are osteoblastic. They will help in bone formation. We know that, right? Remember the PCM, prostate, carcinoid, and medullary cancer of thyroid. Osteoblastic secondaries they form. Treatment for early cancer. Early cancer, that means T1 or T2A. Without nodes, that means the disease is still inside the prostate. You must know that this is a slow growing cancer. Fine. Now we will do radical prostatectomy only if the patient has more than 10 years to live, or the patient is too young, less than 70 years of age. What all do we remove in radical prostatectomy? Prostate, seminal vesicle, obturator, and iliac lymph nodes. Right now, if the patient age is more than 70 years, or the patient life expectancy is less than 10 years, for example, your patient is 90 years old, why to give the trauma of surgery? Right? So they will just do observation of the patient. Right? No need of anything active. Now, if the disease has gone beyond the prostate, if the disease has gone beyond the prostate or is, advanced, T2B, advanced disease, right? Now here, what will we do? Radiotherapy, brachytherapy. That means we will insert the source of radiation inside the body, palladium needle inside the body. And after radiotherapy, the cancer must have reduced. Now we will do salvage surgery. That means now we will perform radical prostatectomy. Iodine 125 is also used in the management. Remember, there was a question about this about 2 years ago. Now, radiopharmaceutical therapy is combination of medicine and radiotherapy, strontium 89 and radium 221. Now, if the cancer has become metastatic, we just need to reduce the testosterone levels so that the growth of cancer stops. Right? How can we do that? One is by surgical method. Remove the seminiferous tubules with the help of subcapsular orchidectomy. Testosterone levels will fall. Another is medical anti-androgen therapy. Remember, this line is important. Physiology. Testosterone is secreted when the testes are stimulated by pulsatile, not continuous, but pulsatile release of luteinizing hormone release hormone. If there is continuous supply of luteinizing hormone release hormone, this will actually decrease the testosterone production. So understand, luteinizing hormone release hormone is necessary for testosterone production, but it should be pulsatile, not continuous. Right? So what we can do is we can use LHRH analog. So that will ensure continuous supply of LHRH, testosterone level will fall. We can use LHRH antagonists like Dejarelix. Testosterone will not be produced at all. Remember, testosterone production requires LHRH, right? Okay, then we can use direct anti-androgens like bicalutamide, flutamide, newer generation enzalutamide, abiraterone. Chemotherapy is based on paclitaxel and docetaxel, while sipuleucel is being touted as vaccine for carcinoma prostate. Right? So these are the different things which we can use in your patient, different things which we can use in your patient. That was all about carcinoma prostate.